Welcome everyone in attendance to our Breaking News Town Hall webinar, Facing the Coronavirus, Human Factors Considerations. Thank you all for joining me. My name is Anthony Andre, and I am your host and organizer for this webinar, and my co-organizers and co-hosts are Dr. Eric Bergman and Dr. Joe Keebler. We have an exciting group of panelists to present to you, and we look forward as well to your interaction and contribution to our discussion over the next couple of hours. Now, before we get into the actual topic of the webinar, let me just briefly discuss what led us to holding this webinar, which is, of course, the virus outbreak and the ultimate very difficult decision we had to cancel the symposium that was planned for Toronto to start this week on Monday. So that was very unfortunate, but I think we made the correct decision. And just a few details about what next for the symposium. We are going to be holding the symposium, but as a virtual symposium, either in mid-May or early June. We will be identifying the dates in the next day or two, and we'll communicate those. It's going to be a 4-day event. It will include workshops on the first day, and then an opportunity for all lecture and poster presenters who were planning to present their work in Toronto to present their work as part of this virtual symposium. There's going to be multiple tracks. It's going to be a big event, and we're really excited about it. There may also be opportunities for new presenters as well, and we'll probably be adding some discussions on this topic, both in this symposium and pushing into the annual meeting. I also want to remind you that everyone who was accepted to present a lecture or poster or panel at the meeting that was scheduled for Toronto can still publish in our proceedings, which will be published after the virtual symposium. But you should know we are not pushing any of our content to the annual meeting, which has its own healthcare track and for which submissions have already closed. So more details to come. Feel free to email HFES or me if you have any questions about the symposium cancellation, refunds, or the virtual symposium. Also, save the date because we're going to make next year bigger and better than ever in Orlando, March 21st through the 24th. We're expanding the conference a bit, both to accommodate what happened this year, but also just as part of our natural growing evolution. So we're really excited. We're going to be near Joe's home turf out there in Florida, and we're very excited to be in Orlando next year in March. Okay, to the webinar in question. Obviously, this was put together very quickly. We wanted to have a touch point with our members and our audience from the symposium, especially given that the outbreak is the reason for our cancellation. However, it is rather organic and we hope very participatory. Just a few pieces of breaking news related to it. The WHO just declared the coronavirus a pandemic today. There's an excellent tracker put out by Johns Hopkins that really nicely shows where cases are confirmed around the world. You might want to check out. And I think one of the purposes of this webinar is to talk about how we can, if I can use the phrase presented here, flatten the curve and slow the spread and eventually help stop it through the discipline, methods, and science of human factors. So that brings me to this slide. Why are we holding this webinar? It's because we think there's human factors implications for pandemics, for virus outbreaks, and other health crises around the world for which we can have a larger contribution. I've just listed some of the areas of human factors that I think apply to a public health crisis, and I'm sure our panelists will bring out even others. But I think we'll all agree we're not as involved in the world community for health crises as we can be. So I'm hoping this webinar and continued discussions on this topic will lead more of us to get involved and lead our community and our society to get involved at a higher level. Okay, so we have an excellent lineup of presenters, and we're so appreciative that they took time out of dealing with the crisis personally and professionally, and with so little time to prepare, but we think it'll be a great way to start the conversation. This is really the start of the conversation of our role in health crises, not the end of it. And I'll see, is Terry on yet? I think I see him dialed in. Terry, if you want to start and can take over the screen and share, we can go that route.
Sorry, Terry Fairbanks is actually just called into an emergency meeting and stepped out of his office for a moment.
Okay, I'll start with someone else then. All right, so then we are going to go to Dr. Ayşe Gürses. Ayşe is with the Armstrong Institute, part of Johns Hopkins, and I know she knows how to take over and screen share. So we're going to go with Ayşe. And actually, Ayşe, before you start, let me just present one last slide about some rules of the webinar. The attendees are all muted. However, we do want your participation. We want you to use the Q&A function, not the chat feature, but it's called Q&A, to submit questions, comments, etc. Please try to limit your questions and comments about this webinar topic. Anything else about the symposium or HFES or problems with your AV, please contact HFES directly. You can submit questions or comments anytime. Eric Bergman will then present selected questions and comments to the presenters when they're done speaking. And this is being recorded and takes at least 24 hours, and then it will be posted on the HFES website. Okay, with that stated, Ayşe, you can take over anytime.
Okay, does it work?
Yes, we see your screen.
Perfect. Thank you, Tony, and thank you, everyone. I am Ayşe Gürses. I am an associate professor at Johns Hopkins University School of Medicine, and I'm also the director of the Armstrong Institute Center for Healthcare Human Factors. I am very happy to be here. I'm not very happy that we are dealing with coronavirus, but I'm glad that we were able to pull a group of speakers and organize this session pretty quickly. It is really amazing. So just as an introduction, in addition to my industrial engineering background, my human factors engineering background, I also have formal training in public health with a master's in public health. So that gave me some ideas about how HFE and public health are so actually related, and I want to point out to some of these if time allows. So I will talk about how HFE can help with the current pandemic and beyond, because we need to be actually working on the next pandemic preparation now. And it is not too late, of course, to work on the current one, but we could have probably all done better with our preparations. And the question is, can human factors help? Can human factors and ergonomics help? Yes, definitely. Actually, there are so many ways it can help. And I want to highlight the fact that although I am primarily a researcher, I also help the hospital here, Hopkins, from time to time do some practical improvements. And actually, I was just in a simulation going through pediatric ambulatory preparations for the coronavirus. So I want to highlight that we are all in this together, whether we are practitioners, researchers, HFE, non-HFE, because practice and research are, to me, very related. I don't have any research that is not has implications for practice. So with that, how can HFE help? HFE today, we were doing, for example, proactive risk assessment. Of course, we are not perhaps having time to do the entire very methodological, rigorous failure modes effects analysis, but it is still, we can still do a lot, even in such a short time. And we were doing this morning some risk assessment informed workflow design, checklist design, etc. When a patient comes to a pediatric ambulatory care, what should be the, what should we do? What should be the steps, etc. I will talk more about that. We can help a lot with training materials. We can help with usability evaluation of the guidelines themselves. Just developing some guidelines and pushing them out doesn't mean that those guidelines can be easily translated into practice. We can do a lot on teamwork and coordination. This is where most of the time failures occur. Communication, and communication, it is very interesting what we are hearing and what kind of emails we are each getting about how this additional information is clarifying everything about what we are doing, although it is actually adding more confusion. We need to look at, we can help with improve work processes. We can help design tools, technologies that are better. In this case, in the last epidemic, Ebola, we were helping design the PPE, redesign the PPE. That's the picture you see here, and many others. So just as a background, I was fortunate to lead this effort when 2014 Ebola epidemic hit. CDC was releasing guidelines, and I was actually on the phone with CDC while they were developing the guidelines. We were developing an HF risk analysis informed training, web-based training. We had only 10 days. So I led a team of 40 people, a multidisciplinary team, infection prevention control, Hopkins, non-Hopkins, patients, nurses, etc. And we used a human factors engineering approach informed by several of our more research-based models, but very practical models, such as the SIPS model, systems ambiguity framework, or teamwork training. And we actually developed the training that was posted on CDC's website. Was this the best training ever? Probably not, because we had only 10 days to do the entire thing. But it was better than, it was much better than, and viewed by 500,000 people within the few months that it was published. Then, and some of this is a great example of how in 10 days even, we can develop some human factors informed training as one intervention in terms of practice. So I want to make some key points. I think we need to, the point one is HFE is needed like desperately, I think, and everywhere. And each HFE subspecialization is relevant. For example, when I was looking at the pediatric ambulatory clinical simulations we were doing together this morning and the last few days, physical ergonomics issues arise. Okay, we will put this patient to this room, then we will put the isolation cart there, but the hallway is so narrow. What happens if there's a fire alarm? These types of questions. Then the patient rooms. This is a relatively old building, and how will we view even see the patient? Can we have situational awareness other than the phone of this patient by looking through the window of the door? Yes, if the door has a window, you can do that. But if there is no window, which we didn't, then what is the risk mitigation strategy there? Should we put a monitor, camera, etc.? These are things we don't know also. A lot of room for tool and checklist development we have found. Just telling people, just telling patients, stay in the room, don't get out, or just telling care providers, care professionals, do this, do that, isn't the most reliable thing. So perhaps we can develop some HF-informed tools, checklists to support our verbal communication. And that is definitely a big need that I see. And also we need to look at the entire system, macro-ergo approach, because it is where most of these failures are occurring. Why then we don't, we wait? One of the reasons why we wait till last minute is, I think, the workflows and process design is so important, but it is not that tangible. It is not like a particular technology or tool. Putting things together is so important and where failures occur. But until we did some of these simulations in the pediatric ambulatory setting, nobody realized some of the potential failure modes. Just because a process, sometimes, I mean, most of the time, even a process isn't even designed. So we don't even realize something may fail, something is wrong with the process until it fails. So one of my questions to the audience or our other panelists is, how can we get more attention to process design and redesign and importance of this ahead of time? Key point 3 is, how can we support distributed cognitive work and teamwork? There are multiple people in this. When a patient comes in, how will we, who will take the patient to the room? Who will escort the patient to the isolation room? Who will prepare the isolation room? Team clarity, role clarity examples. What will be the role of the patient and family member escorting, who is with the patient, and the rest of the family members who are not, who are actually asked to leave the building? What are their roles in this entire pandemic situation? Communication, these are some of the emails that actually Dr. Perry sent me this one. After a huge email chain that tries to clarify what to do in terms of supplies and kits and testing, then they sent another email saying, please read this carefully as this explains and clarifies testing procedures. So I want to highlight two words there, as you can see, as if carefulness, paying attention is the main problem. That is the way we are still trying to put more and more on the healthcare worker and professionals. Read this carefully and you will be fine. And then clarifies testing. That email chain was the most confusing thing I have ever seen. It clarifies, if a person says, if a person may say or may think that they are communicating something, but that doesn't mean that the receiver is actually getting the same information as communicated. These are really important important points. Email communication is very interesting in this pandemic. The other thing, we got an email yesterday. Due to shortage, please do not use gowns as jackets, okay? So this is another example of how sometimes normalization of deviance occurs, and in these situations, you need to turn it back because you don't have enough supplies. How can HFE help? HFE can help with outbreak preparation and beyond. We can definitely help proactively. We have a lot of risk assessment tools, proactive risk assessment approaches that we can help. We definitely need to be actually in the outbreak investigations after the fact, just like when NTSB or any other accident happens, HF experts are there. We should be on the team. We are contributing because to both patient safety and healthcare worker safety and actually public health. We should be, that is my belief. I worked with my colleagues in CDC and really appreciate what they are doing. And I know at least the colleagues I work with work really very, very hard. But I think public health agencies, CDC, state health departments can use much of our expertise. We should be partnering with them, and actually each one of them needs to have some HF on their staff. Here is an example from not specifically coronavirus, but a study I recently was involved in, just to show how reliable our processes are. Yes, we have coronavirus now, but it is basically on top of the issues that are being problems now are basically built upon a system that is already not reliable. So this is some data we had. We were observing patient rooms, direct observations of 89 rooms in terms of patient room cleaning, the environmental cleaning. And as you can see, the red, the closer you are to the patient bed and patient bed area, the less likely that place is cleaned by the environmental care. And what does that mean? How reliable we are? So today I go to pediatric ambulatory care simulations and I ask them, okay, how are you involving environmental care? They just talking to their supervisor isn't enough. They should be part of the team that is preparing the ambulatory care or whatever setting you are working on in the healthcare. They should be part of the team doing some of these simulations and proactive analysis. So in short, I can give tons of examples. So another example is we don't need to wait for some of these preparations to occur until an epidemic arises. We can have a much more modular approach, and I can talk more about that during the question answer session. But in short, we need a participatory approach. We need even patient family representatives to be on the table while we are developing ahead of time our efforts and preparation for such a response. It is really key for all of us to be involved in this. The partnership among all stakeholders, including HFE, is absolutely necessary. I think we should think about how we can make sure our voice and input is much more heard by public health agencies and hospitals, so that HFE expertise is infused into this preparation processes much more effectively. With that, thank you and stay safe, please.
Okay, thank you, Aisha. This is Eric Bergman. We're still taking questions for Aisha in that last presentation. And we already have a few. Glad to take some more. I'd like to start out with one overall question, which was, how can HEFES, both the organization and the community, support CDC in their work?
I mean, I think we need to, first of all, we should talk with them. The HFES perhaps should talk with CDC. That is one approach. I already asked them yesterday. I emailed them saying, as part of Armstrong Institute, I'm happy to help. We are happy to help. So I have worked with them in the past, but I don't have much more control than that or power than that. So I worked with them in the past. I worked with them on several grants, contracts, more for research purposes. There are many, many ways we can help, I think. But it becomes a leadership issue. It becomes more than one person. It becomes perhaps our society and a representative group of us talking with representatives from CDC.
And Eric, it's Terry Fairbanks. I just wanted to let you know I'm on now. I apologize.
Okay, thank you. So I just wanted to have a follow-up question on that room cleaning study that you presented. There was a question regarding whether it would be fair to extrapolate that virus spreading may be caused less by an individual who's sick once they're in the room and more on families and visitors carrying the virus to others. And then the questioner asked, with that in mind, what system could be put in place to ensure families do a checklist since they are not required to follow checklists? So essentially, I guess, how can families coming into the environment be addressed, that risk around them coming in the environment?
Yeah. So if I understood the question correctly, how can families, we can help families help us, basically. I think there are, depending, this is a huge question, can be a huge question. It affects not only coronavirus, it affects, it is everywhere in healthcare. We really need to find smarter ways, better ways to partner with the family. Family is part of the team. In this case, in this particular case, one practical example we were discussing this morning is, okay, one family member came and can stay with the child in the isolation room, okay, but then what happens to the rest of the family? If they want to, they are not allowed in the isolation room, only one person. So how will we communicate this information to family? You can communicate this verbally, but some of the information, they need to leave the building, they shouldn't keep coming. I mean, they need to call. There are some rules on visitation. So some of these needs to be both verbally explained, but also if a more serious crisis occurs and there are many patients coming simultaneously, why are we not developing some cognitive tools, some basic checklists or basic information tools to give to the family members on what to do? These are some examples that we can help. Then for the environmental care specifically, this is what we are doing, we have been doing, independent of coronavirus. We have done some interventions in the regular hospital, daily room cleaning, how the environmental care associate introduces himself or herself to the patient and family and say that they need to really clean everywhere, including the patient area. Turns out the environmental care associates are really shy and don't want to, or they don't want to really, not shy, but they don't really want to bother the patient and family. And patient and family views daily room cleaning as hotel room cleaning, as an optional thing, not as a part of their care or safety of their care. So we need to explain to patient and family at the admission to their room, okay, this is part of the care process. Environmental care is part of the care team. Those are some of the interventions we are doing as part of another CDC study in the hospital, independent of coronavirus.
Okay, great. Thank you, Aisha. I'm going to hand off to Tony, who will introduce our next speaker.
All right, yes. Thank you, Aisha. That was awesome. And keep your questions coming. What we'll probably do is after each presenter, we'll ask some questions specific to their presentation, and some of the more general questions we will save for all panelists to answer at the end. So thank you for those who have been submitting questions. Next, we're shuffling the order here and there, but we're going to go to Dr. Terry Fairbanks from MedStar Health. And Terry, if you want to get on the line, and if you have any visuals to share, you can take over the sharing.
I'm on and no visuals.
Okay, no visuals. Then I will just I will just put up a slide, but go ahead. And,
okay,
welcome.
Thank you. And Aisha, I did hear most of your presentation. Nice job, thank you. And I'm sorry to everyone I couldn't be here in the very start. Ironically, I was pulled away to deal with something that was kind of a human factors dilemma, so it's a good story. And so thanks everyone for joining us. And what I'll do, I just want to give a quick history for context on my background and what I'm doing here so that you can give context to my comments. My current role, I'm Vice President for Quality and Safety for the MedStar Health System, which is a 10-hospital, 300 outpatient site health system in the Baltimore and Washington, D.C. and Maryland region, with Georgetown Hospital, Washington Hospital Center, and Franklin Square Hospital are three large academic centers. And then, excuse me, but my background before that, I know many of you from my time developing human factors program at MedStar Health and the MedStar Institute for Innovation, the National Center for Human Factors in Healthcare, which is an integrated program with human factors professionals and scientists integrated with clinicians. And I'm an emergency physician. I work at the Washington Hospital Center. Prior to that, in going into medicine, I had my human factors master's prior to going to medical school, and I was a paramedic. So all of what I'm going to talk about today brings all parts of my life together, because as a paramedic, I was involved in mass casualty incidents, several of them over the years, and I was involved later as I did leadership roles and later as an EMS medical director in disaster planning. And then during the Ebola event at MedStar, I was responsible for human factors and responsible for our simulation and training organization. So I was involved in that response for doing real-time training pieces as we were quickly worried about version control and changing over quick moments as the requirements for the garb and the way that our protective equipment was worn and what was required. And it was very complex training for our associates. And I was involved in our different systems, helping develop our different systems that helped do screening so that we didn't miss somebody who was at risk. And then transitioning to now I'm at MedStar Health. In my role, I have the infection preventionists that roll up under my team. And so I'm very involved in supporting them. And then I report to the chief medical officer for the system, who's the designated emergency and disaster preparedness officer and chief incident commander for our system. So I've become also a member of his team in dealing with different things that don't have direct influence, or usually not in my direct area of accountability. So I'm deep into this now, and that's why I don't have slides, but I do have observations on some of the kind of key areas that I think human factors dilemmas have been encountered by us and our teams as we're trying to move through things. So that's what I want to do is just kind of give you some general thoughts and then give you some examples. And what I will say is we've deployed our human factors team. And in fact, last night I called Raj Ratwani, who is leading our human factors group, and asked him for more help. And we also have members of our direct quality and safety team who are human factors trained, who are deep into helping us with different pieces in this. And the major dilemmas that we're facing, Aisha noted, have to do with real-time communication to it. We have 30,000 employees, and we have about 700 leaders who are deploying our messages to those 30,000 employees. And this kind of work affects everybody, from the dietary folks who's going in the room to the transportation folks, the respiratory therapy, and of course nurses, providers, physicians, nurse practitioners, respiratory therapists, our flight paramedics, all the way down. And each hour things are changing. And as an example, 2 days ago, we had a change in a CDC requirement that affected a communication for us. And then 4 hours later, when we got home after getting that communication out, they had changed the criteria so that we had to revise it very quickly. And what I'm finding is that there are many, many, many human factors dilemmas that are affecting our ability to communicate. From some things as simple as having salient message on our communications, they're cascaded down largely through email, to the leaders that are receiving these so that they understand whether they are receiving the memos and the updates as an FYI, or if they're receiving these with accountability for then ensuring that each person in their area of responsibility gets the message. And the second is the form of messaging, if you will, the usability of the messaging that we're doing, where we're trying to have a balance between controlling the worry of our associates and also control the worry of our patients and their families in a way that's realistic without being over optimistic and realistic, and justifying the decisions that are being made and being able to demonstrate to them the justification behind them. And that is a tough balance because you also don't want to have too much text and have the important critical messages be lost. And what we are finding is, I'm just going to give you some very specific examples in what I would say is our chief dilemma, and that is the usability of communication instruments. And that is that we find that there are sometimes complex decision algorithms. And for example, one thing that is changing frequently as new information is learned about the virus and as there becomes an increased availability of testing and an increase in the places you can have the testing done, which, just as a side note, started out only the CDC, so there was a whole complex process and very restricted indications for testing. And remember, if you have 30,000 employees, everyone has to understand when patients are coming into 300 different avenues what these are. At that point, you have to go to the State Department of Health. And the State Department of Health did a full evaluation and then decided if they agreed that there was an indication for testing. And then they would contact the CDC, and then they would do a full evaluation. And this would take hours of paperwork, time, phone calls, and it was a major disruption in normal care of patients because in addition to this, taking the staff offline to do all of this communication, you had to take a room offline, and you had to take the area offline if people weren't properly masked in the door in the way in order to clean. So that rapidly changed as the states were started to be able to do their own tests and started to have the equipment. Our health system early on, when this was anticipated based on the activity in China, ordered the equipment to be able to do our own tests, and there's been a long process to get FDA approval and to be able to put the tests into the computer ordering system. And as that becomes available, we've had to roll out what locations are able to do the testing. And the complexity of that is multifactorial because, first of all, the public anticipates that people can get testing in any doctor's office. But normal outpatient clinics like a family medicine office or a GI clinic, et cetera, does not usually see infective patients, so they don't have training or fit testing or equipment for the very specialized N95 respirator masks, which for certain patients with coronavirus are considered to be necessary. And so I'm probably going down too much of a rabbit hole around the differences, but I think you get the idea of the complexity. So we had to be able to communicate to patients about where they should go, because initially we had only our urgent cares and emergency departments as locations that could do testing. So there was a difference in how we acted. We had to get our patients to call ahead and find out where they should go. And we also were doing what many patients would not expect, and that is sometimes sending them home and saying, don't go anywhere. You can stay home and self-quarantine and call us twice a day with your monitoring. And that's unusual to patients. So we had to script and create talking points and scripts for our literally hundreds of providers and staff members that were having these conversations. Then anyway, so all of these created this usability dilemma with communication. And we would have to take this balance between dense memos where it was hard sometimes to, we very clearly would explain the justification and have people understand the details that people wanted. They wanted the context, but sometimes the main messages would get lost, and then there would be ambiguity and confusion about, at some sites about what should be done. Thank you. Then we would also find that there would sometimes be complex decisions, like we would have text paragraph-based decision algorithms. So it would say, if the patient has X, which would be a 2-sentence description, and underlined, they have one of the following, and then there would be either this paragraph or this paragraph or this paragraph, then call the health department, et cetera. And so one of the things we have our human factors team working on is taking those decision algorithms that are created on the CDC website in text and then adapted to our practice environment and put out in memos into decision algorithms, if you will, kind of similar to an ACLS algorithm or an EMS protocol that's like a flow chart decision algorithm. So it becomes much more clear to people, and have that as an attachment in these memos. So you have the justification on one page and then an attachment on others, and then also repurpose that in ways that it can go up on bathroom stalls and in staff areas, make it available off the network so that people can retrieve it when they're working from home, which is happening at an increased basis, or when they're off-site. So the usability, I think the usability of communication tools and of decision algorithms has been a major piece for us. The second piece has been, it's kind of related, but it's being able to describe to people the conversations that they should have with patients, because we have patients and families calling. We're now asking them in all of our public information, which includes emails to patients, the phone calls, and the texts that patients get in advance of a routine appointment. And instead of saying we're verifying your appointment for next Thursday, we're also saying if you have any symptoms of a cold, runny nose, fever, any respiratory issues, please call ahead so that you can get advice on what to do. And we haven't had any decrease in patient volume or increase in staffing to allow these phone calls that normally are hard for our providers to find time to do anyway. And so we're left with our frontline staff, most of whom have minimal or no registration or no training beyond registration, no medical training, left with managing these calls. So we're very quickly trying to develop scripts for them, something beyond the memo about what they should be telling patients. So they have talking points and in some cases, actual scripts. And we have to make sure this is in the work as done space and it's actually working for them. So we're trying to do iterative design. And I'll give one last kind of separate but smaller issue, and that is There's rapid fire on usability of new devices. As I think all of you know, there's a perceived potential shortage of the N95 respirators. Although the good news is the CDC is telling us they're probably not necessary except in cases of aerosolized like BiPAP machines and aerosolized breath and close procedures and ICU care. So we probably will have less of a dilemma with that. But what's happening is our teams are getting sent by vendors all kinds of N95 masks that we've never seen before. And so we're trying to do evaluations to see if they actually have correct fit testing and whether they could be considered as a contingency plan. So that's another potential use for human factors in the team environment. So just looking at my notes here, the other thing I would say, Aisha had a slide, and I think it was number 4, point number 4, if I'm remembering right, where she said, there's pre-planning. Yes, I totally agree. That can really help, especially with getting tools up and running and kind of adapting the hospital incident command system structure to your own environment. But then after event review is huge, and in many of our events, our human factors team has been involved, even small events, obviously, but big ones, like we had a big security breach blackout. We had the Ebola case and others. But what Aisha didn't have on the slide, but she referenced, and that is leadership engagement, is having the leaders at the organizations understand where the value in the human factors teams are during the real-time crisis time. And I think there are many leaders that see human factors as a bonus. If you have time, we'll put it through a cycle, and when you get into crisis mode, we're really busy, we don't have time to do that. And what we've been able to show here is the great benefit of having a human factors team taking things and turning them around very quickly. So when a memo is produced by the normal corporate communications team, and it goes out, and we start to get feedback from our hospitals and sites about which ones they need more clarity on, we give it to the human factors team, and in real time they start producing other instruments and tools, including things like graphics to put up on the screensaver that gets pushed out so every screen in the whole system delivers a message. Little things like that is a real-time aid that I think is a great benefit of human factors teams. And the other piece is related to the communication, but is that the enhancing of teamwork, because you have new teams working together in different ways that have to maintain new situation awareness in areas that they're not used to. It's not like a trauma team that comes together, even though it's different people in the same roles. They're kind of used to the protocol. In disaster management, most of the time, it's like resilience. You've never planned for what you're dealing with, and so communication and situation awareness by the many subject matter experts becomes paramount. So I think I'm at time. I really could talk about this for 3 hours, except my phone has rang 3 times and I've handed it to somebody else. And so it really is, you're talking to me during a real-time event unfolding for our health system, which I should have said in the beginning. Washington, D.C., it was Saturday night when we learned of the first positive community spread in our community, and it was one of our hospitals where that first case was, and since then we've just each day wake up to an exponential growth of cases, so we now have significant community spread. So this week, in the last 4 days, has been the testing of all of our preparations that we've been doing since January when we started to anticipate this. I'd be happy to take questions. I think the point Tony made earlier that I would save questions that you think were relevant to all speakers, but if there's something very specific to me, I think it's a good time now.
Okay, thank you, Dr. Fairbanks. So we do have quite a few questions, but maybe we'll just pick a couple of specific ones. I think one that's probably of great interest to a lot of people is this question: how can a healthcare system that does not have any human factors professional take into consideration human factors concepts and tools in addressing such a pandemic?
Well, what I get questions in normal times about that a lot, and I always say, because especially when we give presentations about the value of human factors in enhancing quality, safety, and other operations, often people will say, well, we don't have a human factors team like you do. And what I say is that there are two things. One is what you can't do is send one of your leaders to a weekend course and then think that you'll have the influence, because we have to remember it's a specialty that people have PhDs and fellowships and careers in, and the whole science is important. However, it's a way of thinking that you can influence how other people think about the approach, and in real time you can get the benefit because nearby to just about every health system, either physically or virtually, is a bed of expertise of people that do this either in the private industry or often in academic centers. And I think particularly in a time of crisis where you have researchers who may be doing social distancing at University of Georgetown, our home university just today announced cancellation of classes and they're managing what researchers will do. You have people that are home with time to help and wondering how they can help in this crisis. And I would say to hospital systems, go to the HFES website, look on the consultant directory page, or go to the HFES website and look at the page where you'll find they have a list of all the graduate programs in human factors around the country. Find a place where you either have a connection or they're physically nearby, or a place that looks like they might have an expertise that you'd like. Call them up and see if you can engage somebody. They don't have to be in your office. Some of these things I think can happen very quickly and in real time with the right relationships.
Okay, thanks, Terry. Another question related to healthcare environment was questioner asks about your thoughts on the HF approach to coronavirus, how they can address and account for the dynamic capacity of health systems during crises. And for example, the questioner says healthcare workers will be or are themselves impacted by COVID-19 and often carry care responsibilities at a higher rate than other sectors. So again, so the problem goes beyond just slowing disease progression.
Right, and yes, it goes beyond it and it's related to it because while I know that we can slow disease progression probably, right now social distancing is what has been successful for China. It's what Italy's main primary approach has been, and countries like Germany that have gotten ahead on it are doing better than the rest of us in terms of expansion of the disease. But closing down schools right now would cause a major dilemma for health systems because then you have a large portion of your workforce with child care issues, and you can't open a child care in a hospital because that would be counterproductive. But at the same time, you don't want your workers getting sick. So some things that have happened dynamically is in the very beginning when our region had only travel spread and no community spread, we were quarantining with a very low threshold. As the pandemic, we look at other countries and what they've had to progress to, you can't quarantine people with minimal exposure because then you very quickly run out of workforce. And so as we think proactively about our decisions about, for example, we're immediately disqualifying any healthcare worker who is immunocompromised from being one of the healthcare workers that takes care of potential coronavirus patients, but we have to have a small exclusion list because what Italy is finding is they've started to run out of healthcare workers in certain roles because so many of their folks have gotten sick. So these kinds of considerations are maybe more logistical planning and preparedness planning than pure human factors, but I think the planning piece of it could have lots of human factors considerations that benefit. And I want to apologize in advance. I do have a hard stop at 3 p.m. Eastern when I have to walk down the hall, so I can probably take one more question.
Okay. Well, in fact, we were about to hand it off, but I think we'll sneak in one more question, given that you will not be available. It sounds like you won't be available for the Q&A at the end. Is that right? Yeah, I apologize. Unless this one, I knew that I had only till 3. The place I'm going, the meeting I'm going to, if it ends, I will leave you on the line, and if it ends, when it ends, I'll come back and see if you're still going. Right. Well, so I mean, I think the general theme is, across a couple of questions was about expectations about various tools and you know, how that can be leveraged across health systems. That there seems to be duplicative work And so is there some source from which we can get these tools, and how quickly are you developing that?
That's a good question, and actually it gave me an opportunity to realize I missed a complete bullet point on here, and that is we have a human factors trained, our informatics human factors medical director, Zach Hettinger, has been literally at the center of the design of all of our EHR solutions. So we had to very quickly put up decision support and put up CPOE tools for ordering tests, for getting the right diagnosis codes, and for doing screening similar to Ebola, so that the right geographic screening for people coming in the door and symptom testing occurs. And doing that in a proactive way with positive cues to our people using the system. So that's a tool that that has been developed with not only deep human factors expertise, but leadership from our human factors team. And we have not shared that. I don't even know, we use Cerner as our tool here. I don't even know if the Cerner leadership knows that we've developed those, and it's a really good point, because those may be things that are transferable to other systems.
Well, that's great. So thank you, Terry. I mean, just regarding that last point, I think that's something we can follow up with HEFES, and clearly there's some interest from our audience in getting access to such tools. So anything we can do afterwards will communicate out. But I'd like to thank Terry and hand off back to Tony. And before I do, just remind everyone that you can continue to submit questions, not only for each speaker, but again, for our overall Q&A at the end.
Great. Thank you, Terry. Thank you, Eric. Next, we're going to move to Dr. SQ Yin, who's staying up very late to be a part of this. SQ is Assistant Director of Human Factors and Systems Design at KK Women's and Children's Hospital in Singapore, where he's joining us from right now. And SQ, go ahead and take over the screen sharing, and welcome to the webinar.
Good morning, everyone. How's my voice? How am I sounding? Am I all right?
You sound good for 2 in the morning your time.
3. But thanks for joining me. Thanks for having me. And there's a lot of familiar faces down in the attendees. So great to see you guys virtually. So I actually talked about being in a research role. Terry talked about he's unable to go deeper into the rabbit hole. I got the chance as an embedded human factors practitioner to go deep into the rabbit hole. So like many of our colleagues and some of the folks even at the Human Factors Transforming Healthcare Network, right? We are the folks that get our hand dirty, and I'll show you some of the things they've uncovered. Where am I? So KK Hospital, we are based in Singapore, and we are the only women's and children's hospital. Therefore, we became the de facto primary outbreak center for all the pediatric cases in Singapore. We had a National Center for Infectious Disease, and it had like dedicated 330 beds for infectious, emerging infectious disease outbreak. But we also had a mandate from the ministry stating that all the public hospitals will ward any suspected COVID-19 cases on site. This is to minimize contamination and transportation and the risks surrounding that process. Background on where we are. So as a reference point, Wuhan and Hubei was locked down on the 23rd of January. That was a day before the Lunar New Year Eve. In fact, from the context of China and even in Asia, the Lunar New Year is a huge festive season for all of us, and especially for China, because it is one of the 2 major block holidays which Chinese tourists would come out of China. And one of their popular locations to visit is Singapore. And we got our first case coming in on the 23rd. We started having this huge wave of Chinese tourists coming to our A&E and our children's emergency simply because they are already in on our island and they feel sick. Moving down the line, so we thought we managed it well. We had 2 weeks. In fact, all of the cases were all imported cases from China, until the one local cluster, the first local cluster where it came from a shop that was interacting, that had Chinese tourists, right? So we had, I think, the first 4 cases of no travel history. Folks, we had no travel history, and soon after we declared DORSCON orange. And then basically we kind of saw a lot more clusters coming up locally. Where are we right now? The strategy has always been to contain and to mitigate. As an embedded human factors practitioner, I have 2 roles. Passively, I am the war journalist. I go down and I document the entire process. It is a 1 in 10 years, or if you count SARS, a 1 in 13-year event, or 1 in 19-year event. Anyway, so it was rare. And I wanted to document all that we have done for this outbreak. Actively, as a human factors practitioner, I help to solve the problems as they appear in front of me. I am the link to the C-suites. I report directly to the chief medical officer. That's my role. I get assigned, incidentally, I get assigned this responsibility of ensuring that the staff has high morale, because typically in outbreaks, we do see very challenging situations. All right, so what I'm gonna do for the next 10 minutes is just to share some of the war stories. I broke it down into the macro, the meso, and the micro level. And if there's any more time, I'll talk briefly about the patient's perspective. Starting with the macro, this is us. We are a public hospital, so most of our wards are shared. We try to care for the general public, which means that a lot of our services are subsidized. We have 1 dedicated isolation ward with 18 beds. And clearly that is not enough, right? If you're talking about an emerging infectious disease outbreak, we needed to create more room. And the more room isn't for the actual cases. Really, what we're trying to do is to contain all the suspects. What we've learned from SARS was we did not arrest the suspects early enough, and we allowed the spread to occur even within the hospital. So there were at least 1 or 2 super spreader events that happened within the hospital, and SARS was scary for us. We lost a few doctors. We lost a few doctors due to that outbreak. So here we were not blessed. We're not blessed like the National Center for Infectious Disease that was designed specifically for an outbreak. So what we had to do, we had to decant all the private room wards. So all the private wards where you get to pay a premium to stay in a private room. We decanted the patients so that all the suspect cases were kept within common locations. We had to create more rooms, and in order to do so, we took over some of the clinics. We basically parked them somewhere else. We turned the consult rooms and even the dental rooms into private rooms, isolation rooms, basically with with negative air pressure. Right. With that, we were able to generate upwards of 50 beds in preparation for the suspect cases. What you don't see really in terms of numbers are the suspect cases. These are the ones that really, really stretch the system. And again, because we are running on the containment and mitigation strategy, we were trying to make sure that we stay ahead of the virus and the outbreak. That meant a few things, right? That meant that the teams, as part of the business continuity planning, we had to break up into teams so that they don't cross paths. We had to have shifts so that there's always a team available, readily available. So with 12-hour shifts, we had more doctors staying behind in the hospitals. We needed to find space for them to rest, right? So you could see the traditional on-call room used to have 1 bed, now is a bunk bed. We turned one of the training rooms into a dormitory. Even the consult room in the ward has a bed in case the doctor was working late, right? And this is the heart of the whole macroeconomics, right? When you talk about